Morning, everybody. Alrighty, I'm gonna take attendance while we wait to see if anybody else will sign on, and then we'll talk about the email I sent y'all on Sunday. Okie dokie, so I am going to screen share the syllabus just so we can all get on the same page here. Okay. All right, so as I said in my email, I recognize this was a ridiculously tough semester for everybody. So I want to allow you some wiggle room, some grace. So you have the option to either drop one of your exams, which are worth 100 points each, or the media project, which is worth 100 points each. And normally I would just do this with exams, but about half of you haven't turned in the media project. So I thought that might be helpful to those of you who haven't. And so what will happen is I will just take your lowest score between those, or the one where you don't have anything if you haven't turned in the media project, and I will exempt that, and then your score will be calculated out of 600 points instead of 7. Everything else will still count the same way. The extra credit will still count the same way from the SONA studies. So is this, again, just giving you all the ability to do what you need to do. So if you do decide to take exam 4, you think you just don't have time to turn in the media project, or you're unhappy with one of your earlier exam grades, you will take it next week. As you can see, we are gonna get through everything this week. This exam 4 is only 2 chapters. So if you wanna try it and see how you do, you can definitely do that. And then if that happens to be your lowest score, I would drop that. And then the other things to keep in mind is I think 2 of the groups have met with me. So the other groups still need to do your meeting with me so I can help guide you for your presentation. And then your presentations are the last day of exams. So 2 weeks from today. And I believe we're actually scheduled for 8, but that's rough for everybody. So I moved them to 9, okay? You know, with the number of presentations we have, we'll still get through them before the end of the exam period, no problem. So again, if you decide you want to take exam 4, then you can just not do the media project if you haven't done it yet. If you decide it would be more helpful for you not to have to take an exam next Tuesday, then you make sure you turn in your media project and your other 3 exam scores will count. So if you are not going to take exam 4, you actually don't even have to come to class next Tuesday. Looks like we got something in the chat. Oh, good question. Someone asked me about for the meeting. So for the group meeting, you want to have one outline that you all have worked on together, and you want to all meet with me simultaneously. And so a couple groups have done this by doing like a Google Doc and sharing it with me, where they've each worked on their pieces. So yeah, I have times on my calendar between now and next Tuesday. So just sign up whenever. Again, I had this as a deadline just to kind of remind you to do it. The big thing is I'm trying to help you make sure you're covering everything well, and also let you know if you're covering too much and it's going to be overwhelming. So, all right, questions, comments, concerns about the new dropping policy. You can either, well, stop sharing so we can see each other on gallery view. You can either type in the chat or you can unmute yourself.
Do we know when we're going to get our grades back for the media project?
I hope to grade them today, actually. So if you planned to turn it in and you're almost done, if you can turn it in by like 2:15 today when I'm done teaching my afternoon class, I'll get them graded. Yeah, good question. Yeah, I've been kind of waiting so I could grade them all at once. But like I said, there's still about half of you who haven't turned them in. So it's not fair to those of you who did to make you keep waiting. Alrighty. Well, if as you are thinking about your options, you have questions, you can always shoot me an email. Feel free to, talk to me after class today or Thursday, and then we will go from there. I'm just making sure I check in the folks who signed in while I was chatting. Awesome. And I will dive in. So today we're probably going to finish the substance use lecture. But if we don't, the personality one can fit on Thursday pretty easily. We've already kind of like talked tangentially about a lot of the personality disorders. So certainly we can cover them fairly efficiently. And I just need to double check where we left off the other day. Make sure.
Simba hasn't visited us in a while.
What's that?
I was joking. I said we hadn't seen Simba in a while.
Oh, yeah. So he, this is actually a funny story. So we used to have this bin downstairs that like something else came in and he decided that was his bed. So we put a little pad in there for him. And then Quinn likes to climb in that bin. And so she took the pad out and put it on top of his other bed. And now he like doesn't leave it because it's like double bed. We'll see. He might come up though. He has been coming to my afternoon class. He just gets lazy sometimes. Alrighty. So we were on nicotine. So I'm going to make sure we get there. So we're talking about the stimulants. And again, just to remind you, the stimulants are uppers essentially. They are things that give you energy, but obviously not in the healthiest way possible, right? And some of them are fine, like caffeine, right? And some of them you want to avoid, like cocaine. And certainly I think nicotine, which we'll start talking about now, is one that we all know the health risks associated with smoking. They're not necessarily directly the result of the nicotine itself, but all the other stuff that's in there. That being said, anytime you inhale something into your lungs that's not like, you know, an inhaler, medication, what have you, it's not good for you. So, you know, this is one that we all know has health impacts, right? And so I know this is really hard to quit. We'll talk about that as part of this, but highly recommend just for your own health that if you are a smoker, you at least ponder quitting. Because of all of the implications. So we're going to talk about nicotine. So about 25% of Americans over 12 do smoke still. Whoops. I like that it worked for 2 seconds and now it's not going to. There we go. Okay. So, smoking has been directly tied to a lot of health issues: high blood pressure, heart disease, lung disease, cancer, strokes. If you smoke while you're pregnant, it has a higher chance of you delivering a premature baby or an underweight baby. Again, remember, the stimulants have that appetite suppressant effect. And there are certainly cases of, say, people with eating disorders who smoke to try to suppress their appetite. So, you know, it has that effect. It does excite the central nervous system, like any other stimulant. Here is the thing that will probably surprise you the most about nicotine. Nicotine is as addictive as heroin. I'm going to say that again because a lot of people are like, what? When I say that, nicotine is as addictive as heroin. And the studies have shown it's at least as addictive as heroin. So if you yourself have been trying to quit and struggling, or you know someone in your life who always seems like they're trying to quit and then they go back to it, this is a big part of the reason why. Nicotine is highly, highly addictive, and that makes it really hard to stop. Regular smokers develop a tolerance to the nicotine and must smoke more and more and more to get the same results. So this is where you'll have, someone who started with 1 cigarette a day. Over time, they end up being like a 2-pack a day smoker, right? Because they've built up that tolerance. It's also been argued that cigarette companies place other chemicals in cigarettes to make them even more addictive than just the nicotine alone. When people go through withdrawal from nicotine, then typically they experience symptoms like irritability, increased appetite because they've been taking an appetite suppressant, sleep disturbances, slower metabolism, cognitive difficulties, so difficulties with memory and attention, and just a power desire to smoke, obviously. So the really interesting thing about the attention piece is, again, this is a stimulant. And for those of you who are familiar with disorders like ADHD, you'll know that the things that are prescribed for ADHD are actually stimulants, which sounds very counterintuitive until you figure out that the part of the brain those particular stimulants act on is right up here. It's your prefrontal cortex, where your executive function lies. And your executive function is what allows you to inhibit behaviors you shouldn't be doing. It's what allows you to inhibit those distractions and pay attention. So there are actually cases of people with, say, like adult ADHD that's never been diagnosed, where they will go like smoke before they have an important project or something like that. Or if they're in college, they'll smoke before they take a test, and they're essentially self-medicating. This ad on this page is like mind-boggling to me because I have asthma, but I'm also allergic to tobacco. So these would like immediately kill me, probably. Like, I've never smoked because I know of that allergy, but when people have accidentally blown smoke in my face, I do have a pretty scary asthma attack. So yeah, again, just sort of amusing. All right, so I mentioned Adderall and other medications that are prescribed for ADHD. Sorry, allergy season here. And so these are fine when they're used as prescribed, but like the opioids, these are bad when you misuse them, okay? So these do help with focus and are usually prescribed for ADHD. And 1 in 5 college students are taking them, but not all of that 20% is prescribed. So there is a black market for these. And certainly, like all the other drugs, you build up tolerance and you need to take more. When I was, I think in like late high school, early college, there were actually cases that came to light where psychiatrists would prescribe these to people who didn't need them. Like rich parents would pay off the psychiatrists to prescribe these so their kids could better study for the SAT. Super duper sketchy, and I hope those people lost their licenses. Because the risks with this, again, especially if you don't need to be taking it, or if you're taking a higher dose than you should, people with heart abnormalities have suddenly just died after taking Adderall. Strokes, heart attacks, hypertension, which is another word for high blood pressure. If you take too much, you can get symptoms of psychosis or seizures, or it can make you really aggressive. So just like any other drug that, we shouldn't just misuse or casually use, you have to be careful. If you are someone who is on Adderall and it's prescribed, and you're using it as prescribed, you don't need to worry about any of these things. Okay, so now we're going to move on and talk about the hallucinogens. And it's good that we just talked about psychosis because that's really the main effect of this. So they induce changes in sensory perceptions on purpose. Like people seek them out for that reason. They may strengthen normal perceptions, or they may include illusions and hallucinations. So illusions are like less dramatic hallucinations. It would be like sort of actually hearing someone else talking to you, or like maybe it looks like the wall is breathing or something like that. They're also known as psychedelics. So if you've ever heard someone refer to the psychedelic medication or heard in an old movie, people say, psychedelic man. That's where this vernacular comes from. And they include such drugs as LSD, mescaline, and ecstasy. Many of these substances come from plants or animals, but others are synthetic, meaning they're produced in laboratories. And again, anytime something is being produced in a laboratory that's not sterile, right? Carefully monitored, you have to worry about what else might be in there. So LSD is a hallucinogenic that causes what's called hallucinosis or hallucinogen intoxication. So just like drunkenness is alcohol intoxication, hallucinosis is LSD intoxication. So this is a general strengthening of perceptions. It also causes psychological changes and physical symptoms. So people may focus on really small details like single blades of grass or the pores on someone's skin, or they may experience color enhancement, or everything may take on a certain shade of pink or purple. I remember in science class in high school, we watched a movie where I think it might have been chemistry. The guy was talking about experiences and he said, you know, I remember being at this museum and looking at this artifact, and it was the most beautiful purple I'd ever seen. It was just so vibrant. And then like on camera, he went back and looked at the same artifact and he's like, yeah, it's just not the same as when I was on LSD. And like, you didn't know that's where the story was going. So you were like, whoa, so it certainly can enhance things beyond what you would normally perceive. As I mentioned, illusions are where objects seem to be distorted, or they may appear to move, breathe, or change shape. And LSD produces these effects by binding to neurons that normally receive serotonin. So it mimics serotonin, basically. And because the serotonin is responsible not only for emotions we've talked about, but also for some functions related to vision, LSD is altering these sensations. Now, the other story I always have to tell here, because it just tickles me so much, is the story of how LSD was discovered. So, and this was told to me by my first year chemistry professor when I was in college, who looked just like Santa Claus. So imagine a guy who's like maybe my height, rotund, big white beard, telling this story. And so this guy who was a chemist working on, certain things, did what you should never do if you're a scientist, and ate lunch at his lab bench. Don't do that. It's bad, right? So what he was working on, which turned out to be LSD, got into his sandwich. And he realized that it had effects on the human body. And so rather than just being like, oops, shouldn't do that again, he decided to experiment on himself. And so he started purposely ingesting it and keeping a journal. And apparently one of his entries, when he had taken a fairly high dose, was just ended with like, ha, 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 ha. So great, fun story about weird science. And again, imagine someone who looks like Santa Claus telling that story. Alrighty, a stimulant and hallucinogenic drug is ecstasy. This is also called X or MDMA. And so it has both hallucinogenic and stimulant properties. So it's similar in its stimulant properties to amphetamines, but it has those hallucinogenic effects. So it raises the mood, it gives you an energy boost, and it's favored as a club drug for these reasons. So ecstasy is what you would take at a rave, for example. And down here you can see just some of the ways ecstasy can be branded. So again, this is something that's produced in a lab. You don't always know the conditions. You don't always know what else is mixed in, right? So that can be something that's a little problematic. The ecstasy.
I'm sorry.
Oh yeah, go ahead.
Wasn't MDMA originally created to use in therapy and to enhance the relationship between the therapist and the patient and to be used in couples therapy? I've heard about that. I don't know if it's true.
I've never heard of that specifically, although now I'll have to look that up for sure. But I know there's been plenty of drugs that have been tried in therapy like this, right? So it wouldn't surprise me. And in fact, there's even a wave now over, I would say, the past like 4 or 5 years, something like that, of trying to use hallucinogenics again to treat people in therapy. And certainly there are some horror stories about experiments they did in the 60s where they just like gave people stuff and they didn't tell them. There's a woman at my church who told me a story when she found out I was a psychologist of, yeah, I went in for the study and they gave me something and I didn't know what it was, but then I was hallucinating. I'm just like, oh my God, like how did they not like do informed consent for this, right? But it was the Wild Wild West. But yeah, that'd be interesting. I'll have to look that up and see.
I think that was all part of, not this with ecstasy, but LSD. It was all part of MK5 Ultra.
I couldn't think of the first
project. So
MK5 Ultra, for those who don't know, was a really sketchy series of experiments done by the CIA to basically see what will happen if we give people this.
mm-hmm. And they were doing experiments with LSD and they were doing trials. And basically the way it leaked into the general population was that some people started stealing it and giving it to their friends. And that's how it created like a whole cultural movement in the 60s because the CIA messed up. So that's,
Yeah, like I said, it used to be sort of the Wild Wild West for experimentation. And it's so interesting because obviously if you've taken part in a study at Wesleyan, you know, we have an informed consent. If that's printed out, it's like a page front and back. I'm actually currently doing the baseline as a participant in a medical trial. And when I went to do my initial baseline appointment, I had to read a 17-page consent form, right? And like, that's what they should have had back then for things like this, but like IRBs didn't exist. There were no regulations saying you had to do that. And there were even more horrible things that happened. So if you're not familiar with like the Tuskegee syphilis experiments, they purposely infected African-American men. And even though they had a treatment, didn't treat them to see like, what will syphilis do to the body? And again, no informed consent. It's totally awful. So we've come a really long way. But yeah, we have very sketchy pasts, both in psychology and in medicine in terms of and obviously the intelligence agencies. Yeah, in therapy. Yeah, again, like I mentioned, Freud was just like, let's try cocaine as an antidepressant. And then he got himself addicted, right? So yeah, we figuring stuff out, you know, again, without a lot of oversight, things don't always go well. Yeah, great points and great questions, Romina. Thank you. Yeah, so obviously there are dangers. We know there are dangers of ecstasy, right? The major psychological issues you run into are confusion. After you come down from the high, you'll actually feel symptoms of depression. You'll have difficulty sleeping. You'll get anxiety. And you may even experience paranoia. And these continue for weeks afterwards, even if you've only taken it one time. There's impairment of memory and other cognitive functions. And then you get physical symptoms as well. Muscle tension, nausea, blurred vision, faintness, chills or sweating, clenching and grinding your teeth, like other stimulants, it also increases your heart rate and blood pressure. But one of the really scary things about ecstasy is it also reduces sweating. So then you're at a rave, say, and you are dancing your butt off, but you can't sweat to cool yourself down. So it can actually cause heat stroke. So this is why sometimes you'll see people who are taking ecstasy just carrying around like gallon jugs of water. And now one thing I'll say is like, there are people who just like work out who carry around gallon jugs of water. So it doesn't mean they're taking ecstasy if you see that. If you're at, you know, a party and people are dancing and you see that, maybe, right? But the problem with that is because you can't sweat it out. And if you're on ecstasy, you might not be thinking of going to the bathroom frequently, right? You can actually get water intoxication. And obviously, in extreme cases, that could cause death in and of itself, as we've already talked about. Another physical symptom is ecstasy can actually cause liver damage over time. So why does it have such lasting effects? Again, taking it once, why does it last for weeks? Well, what it does in the brain is it causes all of your serotonin and dopamine to be released at once through the entire brain. So this like gives you a great feeling in the moment, but then that means you don't have any, right, when you come down from the high. So it actually does take weeks afterwards to get back to normal. And then the other problem is that it interferes with your body's ability to produce new serotonin. So as you're trying to make up for this deficit, the lasting effects of ecstasy are keeping that from you. So again, this one is actually probably the top of my don't try this once list, simply because of this, right? This is really bad long-lasting effects on the brain. We've talked all semester about how much serotonin and dopamine are implicated in psychological issues, right? So for that reason, I think that better not, like, love your brain and, you know, try something that's going to be a little less damaging to it. All right, perhaps cannabis, right? So cannabis is being legalized. I think there are even steps to legalize it in Virginia. I think you can now legally grow it, or you will be able to as of July 1st in Virginia. And so cannabis drugs in general are produced from the hemp plant, and this is what it looks like. And there are two primary types, and those are marijuana and hashish. And here in the US, we mostly just see pot, right, marijuana. And cannabis drugs cause a mix of pretty much all the effects we've talked about already. So hallucinogenic, depressant, and stimulant. And especially now that, you know, pot is legal in some places like California and Colorado, and people are super creative, right? By sort of manipulating the strains, Gregor Mendel style, right? You can actually control which of these effects would be most prominent, for example. So again, there are different sort of breed strains of marijuana that will cause slightly different effects. So the active ingredient is tetrahydrocannabinol, or THC. And the greater the content of THC in the marijuana, the more powerful the drug. Hashish contains very large proportions of THC, so it is actually the most powerful cannabis drug. Marijuana tends to contain smaller portions, so it's not as powerful. And the reason I have the picture of the plant on here is because of a story that my mom actually told me. So my mom was a hippie, and so she was growing some pot plants in her closet. This is when she was in high school, so she's still living at home. And her mom found them and was like, "Oh, what a pretty plant!" This is my grandmother who came over on the boat from Poland, like as a child, right? So very sheltered woman. And I just always thought that story was so adorable. So as you can see, like the other things we've talked about, cannabis has traditionally been put into things. So here is something that has codeine in it as well as cannabis. The one that always gets me here is the chloroform. Like, even in small doses, that makes me anxious, right? And as I mentioned before, right, some of the things related to cannabis, like the certain oils. Oh, someone asks, can you actually have hallucinations from smoking cannabis? Yes, again, it depends on sort of the strain that you take. But yeah, there are people who have full-on hallucinations. Sort of a humorous portrayal of this is the movie Harold and Kumar Go to White Castle, where one of the hallucinations they have is seeing Neil Patrick Harris riding a unicorn. Right? So yeah, and it really depends on like how much you smoke or consume, and then you know, again, the strain of it and which ingredients are the most active. That's a really good question, because it really does depend on the strain more than anything else. Plus, obviously, your own chemistry. CBD oil, that's what I was trying to think of. Again, it's in the shampoo I have. People are using it as like essential oils. And so again, I don't know that we have a lot of great research on that. Pot itself does help with pain. That's why it started as medical marijuana. In some of the places it's legal. Oh yeah, someone like, is it only when it's laced with other things? No, there are actually strains of marijuana where you can get these hallucinogenic effects. Yeah, that's a good question. Yeah, but obviously other things can affect it too. This is actually sort of interesting. So while I was in grad school, I actually, like several of my fellow students and I had a debate with one of our professors because he didn't think that like a substance use disorder with marijuana was a thing. He was like, you can't get addicted to pot, but it's like literally in the DSM, right? So we opened it and showed him, right? It's just like anything else, right? Lots of people can drink alcohol without having an alcohol use disorder. And there are plenty of people who can use marijuana without having a substance use disorder. But there are some people who develop it, right? And so this is when you're getting high really regularly, and it's going to negatively affect your work, school, or social functioning. I remember one time I gave like pieces of this particular lecture to a group. It was like a professor in residence. It was like a group from a dorm, basically, that I gave it to. And Keith Moore came, and afterwards he said, you know, like the people who take pot, we don't really worry about them as much because they don't hurt anybody. They just like order pizza. And like, yeah, that can happen, right? But what if you're just sitting around ordering pizza all week and not going to your classes or not going to your job, right? That's where it can really be a problem for you personally. So you can increase your tolerance for the drug and develop dependence. So, and symptoms of dependence can be flu-like symptoms, restlessness, and irritability when you stop smoking and have the withdrawal. So it causes things that can be dangerous, but again, that doesn't mean it's always dangerous. Yeah, and it's possible. I think a lot of addiction, Romina, is more emotional than physical, honestly. Like a lot of people who are addicted to alcohol or smoking use it to cope with negative feelings more than anything else, honestly. And they just can't figure out a better coping mechanism. It's a really good point. Let's see. Some people feel like they're afraid and might be losing their minds. They might panic. I have a friend who in grad school decided she needed to like break out of her shell and like try pot. And she was more straight-laced than me. And she did not enjoy the experience because she was just paranoid the whole time. And like a police car would go by and she'd be like, they're coming for us. They were in an apartment, not bothering anybody. Like, yeah. So this is an effect that, again, some people are going to get more than others. It has been implicated in automobile accidents. Again, it has depressive effects, right? So just like with alcohol, it can slow your reaction time. And that slowing of your reaction time is really what causes the auto accidents with those types of drugs. It can affect your work and school performance, even your social life, just because, you know, you might be spending more and more time. There are implications for lung disease and cancer. Again, as I mentioned with smoking, with cigarettes, anytime you smoke something, it's not good for your lungs. So people have asked me in the past, what about edibles, right? And you're not going to have that smoking problem if you have edibles. Now, does this mean you should go tell everybody that Dr. Meyer said go have some edibles today? Not necessarily, right? But, you know, once it is legal, that would be my recommended route if you do want to partake, simply because you're less likely to have the negative side effects of smoking it. And then it's been shown to reduce sperm count in men and cause abnormal ovulation in women. So it's going to mess with your reproductive system, but if you're not planning on trying to get pregnant anytime soon, probably less of an issue for you. All right, so when I gave this talk in the dorms, spice was sort of a big deal. I think it was banned, as you can see, in 2012, but they used to just sell this like at 7-Eleven. So they wanted me to talk about it at that time. And this is basically just synthetic pot, okay? So similar risks of intoxication, psychosis, cardiovascular issues, elevated blood pressure, even seizures. And at very high doses, like really almost any of these drugs we've talked about, right? You might have increased agitation and vomiting. So, okay, we've talked about these individual substances. Well, what happens if you combine them, right? If you're partying, you might be drinking and also doing, you know, smoking some pot or having some edibles, or you might be, you know, in one of those crazy Wolf of Wall Street scenarios, right? And you're snorting pot, snorting cocaine. Jesus, I'm not that square, I promise. You know, and also again, drinking. So what happens, even something as simple as, you know, having like a Red Bull and vodka, right? Or a rum and Coke, you're actually technically combining a stimulant and a depressant, right? So these things are going to interact with each other, just like if you take a new medication that's prescribed, your pharmacist is going to check it with everything else you're taking, right? To let you know of any interaction effects. And so there is what's called polysubstance abuse or polysubstance use. And this is when you're taking more than one drug at a time. And because it is so common, researchers have investigated how drugs actually interact with each other. And they found there's a couple different ways. So one is cross tolerance may develop. So you might develop tolerance to a drug you're literally taking for the first time because you've been using another drug that's similar. So if you're using amphetamines and you've developed a tolerance and then you try cocaine, you may actually already have a tolerance to the cocaine because they're both stimulants and both produce the same effects on the body. So that's really scary because then you're going to want to take more to get the same effect pretty quickly. And we know these things have like an OD ceiling, right? And then you can die. So there can also be what's called synergistic effects. And this is when more than one drug is acting on the body at the same time. And it causes a multiplication of the effects of each drug. So for example, let's say you were to pair alcohol with benzodiazepines. So you're taking two depressants, right? They may severely suppress the CNS, the central nervous system, much sooner than they typically would. And then you have that risk of death. You can also have antagonistic acting drugs. Again, if you're taking a stimulant and a depressant, those may have weird interactions because they're supposed to have opposite effects on the body. So am I saying never mix substances? No, right? But just be careful and make sure you have friends that you're looking out for each other when you try something new, just because you never know how it's gonna react with your body. Like, people are randomly allergic to drugs sometimes, just like they are prescription drugs, right? So you want to make sure you've got someone who can help you get medical attention if you need it. All right, so now we're going to talk about theories about why these disorders occur. So we'll start with the sociocultural view, just because this really relates to like Romina's last point in the chat. And also to just, I think the way we overall think about these things is that it's caused by a lot of different like emotional and societal situations, in particular stressful socioeconomic conditions like poverty and unemployment. You know, we obviously don't have good data yet, but I would be shocked if substance use didn't skyrocket during the pandemic, because A, people are sitting around at home bored, and B, a lot of people lost their jobs, right? So, you know, that may have long-reaching effects, just like this year of isolation did, just like, you know, the actual physical effects of the virus. Also, it's thought that if someone is in an environment where it's more acceptable to use substances, it's likely there will be higher rates of abuse and dependence if that is the pattern, because it's even expected of the person, and the person may feel more comfortable using a lot of it. Now, this can also go the opposite way. So for example, in Europe, a lot of folks will drink beer or wine with dinner, and they model just, you know, like having a glass, and teenagers start doing this with their families, right? And that is considered completely socially acceptable, and people are actually less likely to abuse when they're not hiding it. But if your family has people in it who are subjected to substance use disorders, right, then you may also sort of think that that's what you should do, kind of mimic it. And that goes into the behavioral view as well. So, you know, we think about social learning, right? Watching what other people around you are doing. They think that operant conditioning plays a role because a person experiences a reduction of tension as a result of drug use, right? Again, like Romina said, there's emotional reasons you take it. You feel better, at least temporarily, when you take it. Again, that's why Freud was thinking cocaine could be an antidepressant. And then because you get that better feeling and you take away the negative feelings, right, then that is negatively reinforcing it. Just like avoidance negatively reinforces your avoidance behaviors and anxiety, right, by taking away the anxiety itself. So Marlatt et al. Gave people an anagram task and criticized them while they were doing it. Like, oh, you're not doing that right. And they found that the people who were criticized drank more alcohol during the alcohol taste test afterwards than people who did not get that criticism. So again, some evidence for alcohol as a coping. That seems pretty obvious to us, right? But sometimes we got to do the research to actually show it is a thing. They also believe that classical conditioning plays a role. So objects present at the time you ingest a drug come to produce the pleasurable effects themselves. So if you're taking an injectable drug, just being around the type of syringe you use might start to produce those same effects. And, you know, if you are if you have a setup for how you do things normally, like your body will start to kick in with that before you actually have consumed the drug. This is potentially really problematic because let's say you usually always take the drug in like the same room of your house and you have the same setup, right? And so you are getting these effects before you actually ingest the drug. Now, let's say you go to take that same drug at a friend's house or a hotel room. Well, your body isn't going to prepare in the same way that it would if you were in your house, right? So it'd be like Pavlov's dogs, right? So they're drooling in the lab when they hear the footsteps of the person, right? But if you took them out on a walk and they're hearing other people walking, they're not going to drool, right? So this is why a lot of times when you hear about celebrities overdosing, you'll hear that they were in someone else's apartment, they were in a hotel room, and it's because of this, that their body, they might have taken the same dose they would usually take, but their body didn't prepare for it, so they overdosed. Okay, so what about biology? The biological view here has two components, looking at genetic predisposition as well as neurotransmitters. So some researchers have found that a normal form of the dopamine 2 receptor gene is linked to substance use disorders. In terms of the biochemical factors, drugs do increase certain neurotransmitters in the brain, NTs, and prolonged drug use reduces the natural production of those. So prolonged drug use with most drugs does what ecstasy does quickly, essentially. Because your body says, well, I'm going to get this through the drug, so I'm going to just compensate by making less. So as drug intake increases, natural production decreases, and they think that this really is the physiological reason tolerance is developed. Because once you begin taking a drug over a long period of time, your body is stopping producing those natural chemicals in order to achieve homeostasis. And because the person no longer receives the chemicals their body naturally produces, they come to need more and more of the drug to get those same effects. And this is why, too, that if you suddenly stop taking one of these drugs, the supply of neurotransmitters will be so low because your body's been relying on the drug rather than naturally producing them. And so the symptoms of withdrawal will develop. And these symptoms will continue until the brain is able to resume its normal production of the neurotransmitters. So the reward center of the brain, sometimes called the pleasure pathway, this is a dopamine-rich pathway in the brain that produces feelings of pleasure when activated, and almost every drug activates this by increasing dopamine levels in the brain. So what can happen when, again, you're using any kind of substance regularly is you get something called reward deficiency syndrome, where this is not activated by other things in your life. So things that might normally be pleasurable, like going to see a movie or taking a walk with a loved one, you won't get any kind of pleasure from. And so the only way you're getting that reward center activated is by taking the substance. All right, so how do we treat this? Well, there's a whole bunch of different things that have been tried. And if someone is truly dependent on a drug, oftentimes they need to go to inpatient treatment so that withdrawal can be carefully monitored for all those physiological symptoms by a medical staff. Aversion therapy is based on classical conditioning. And what happens here is the individual is presented with an unpleasant stimulus when they take the drug. So, and then after repeated pairings, they're expected to react negatively to the substance and lose their craving for it. So for example, you might do this with a low-level electric shock, because your brain will start to associate the pain caused by the shock with drinking alcohol. So the person develops an aversion to the alcohol itself. A couple years ago, I actually saw, I think like an Instagram or Facebook ad for something called the Psych Lock, which was a little bracelet you could wear and do this to yourself and give yourself a mild electric shock to help you break habits, which was interesting marketing, but also made me anxious that, right, people could certainly misuse that and harm themselves. And then you could also try to help people find alternative behaviors for when they're feeling overwhelmed. And in fact, really interestingly, this is a lot of what we do to help treat people with binge eating disorder as well. When you are experiencing those emotions, then what can you do instead? So sometimes it might be simple things, like something to keep your hands busy so you're not going to go drink, right? Knitting or Sudoku or something like that. Maybe it's something more like relaxation or mindfulness meditation. A lot of places incorporate that now. And behavioral therapies, like a lot of the other disorders we've talked about this semester, are really only effective when you combine them with other treatments. You need more than just doing these behavioral things. you have to deal with the thoughts and the emotions. So cognitive behavioral therapies can be very helpful here. One of the techniques used is called behavioral self-control training. We use this in particular with alcohol, and clients keep track of their drinking and start to apply coping strategies in situations that trigger drinking. So they identify times and places where they do typically drink and develop more adaptive ways of coping in these circumstances. So if they realize they drink in social situations to feel more at ease, then they might employ relaxation techniques or learn social skills, assertiveness training to help them feel more comfortable without alcohol. And again, there are different philosophies in terms of like, should you go completely cold turkey and never use the substance again? Or can you, maybe use alcohol socially? A lot of people say you should just go cold turkey, but there are other people who argue, if you can learn to do it in such a way that doesn't feed that addictive behavior, maybe that will work. Biological treatments also exist. These, again, like behavioral treatments, are not too effective alone, but they're helpful in combination with other things. So detox is the big thing. This is the supervised withdrawal from the drug. And they'll give them medications to help them with their withdrawal symptoms as well. And then the most common biological treatment is antagonist drugs. So the most commonly known one of these is Antabuse, which works on alcohol. So these are drugs that block or change the effects of an addictive drug. So if you consume alcohol while taking Antabuse, you immediately start feeling nauseous, dizzy, you might throw up, you might feel faint. So the idea is, again, sort of using a biological helper to get at that classical conditioning idea, right? That you are going to associate this with just feeling awful. So you'll want to stop doing it. Because sociocultural theorists believe that psychological problems emerge in a social setting, they also believe they're best treated in a social setting. So these can include self-help programs like Alcoholics Anonymous, Narcotics Anonymous. These remain very effective, and a lot of inpatient programs will actually include components of these. But outpatient, essentially all of these are run by people who are recovering alcoholics themselves. So there's a big self-help component, and folks who have been in the program longer will help those who haven't. However, I do have to say there are people for whom this does not work, particularly if you're not religious, because Alcoholics Anonymous does include a very large religious component. If you remember, I talked about Dr. Bob and Bill W. in Akron. Well, the hospital they started treating people at was called St. Thomas, and it was religiously affiliated. So that obviously has sort of an impact on how the program was created. So if you are someone who's atheist, agnostic, or just religion doesn't resonate with you, this program might not work that well for you. But for a lot of folks, it does work well. Culture and gender sensitive programs also become really important, particularly because a lot of programs, even like Alcoholics Anonymous meetings, tend to be majority male. So women can feel out of place, right? And maybe not as supported. So you want therapy that's sensitive to their particular life challenges, and this is going to be more effective because it's taking account their life circumstances and stressors. So, just being aware of what's actually going on. And then there are community prevention programs, particularly in schools. And the one that's sort of most well known is DARE, which stands for Drug Awareness Resistance Education. I've heard mixed things about DARE. I went to a private school, so I didn't get DARE. But from what I've heard from people, some people thought it was actually pretty helpful, and there's some research to show it's effective. But other people have told me they thought DARE was sort of like a how-to. Like, oh, those drugs are out there. So obviously it can go either way. Alrighty, so I'm going to switch us over to that personality disorders lecture, and we can kick that off today. While I'm doing that, does anyone have any questions left about substances, alcohol, anything like that? Alrighty. Well, if you think of any, feel free to throw them in the chat because actually they relate pretty well to our next lecture. Not everyone with a personality disorder, but a decent amount of people with personality disorders will also struggle with the substance use issue and have at least one comorbid disorder we've talked about already. Particularly mood and anxiety disorders are pretty common. So personality disorders really are one of the more fascinating categories of disorders. And they are so distinct that up until the DSM-5 in 2013, we actually coded these on a different axis. So like everything else we've talked about this semester would be axis 1, and then personality disorders and developmental delays were axis 2. And that was because they were thought to be much more sort of underlying, long-standing, harder to treat, essentially. They did away with that distinction for DSM-5, but, you know, certainly something to keep in the back of your mind that these are really categorically different in a lot of ways from the disorders we've already talked about. Okay, so what is personality? Well, I know some of you took theories of personality with me last semester, and you would know from that class that like we don't have one good definition of it. But essentially, it's all the ways we have of acting, thinking, believing, and feeling that make each of us unique and different from other people. I'll say that again because it's pretty wordy. A personality is all the ways we have of acting, thinking, believing, and feeling that make us unique and different from every other person. So these are enduring and relatively stable predispositions. Personality is really an individual's characteristic, consistent, predictable ways of acting, perceiving things, feeling things, and relating to others. It's also consistent with the styles and themes in a person's life. Personality disorders are long-standing patterns of thoughts, behavior, and emotions that are maladaptive for the individual and or for the people around them. I'll say that one again too. Personality disorders are long-standing patterns of thought, behavior, and emotions that are maladaptive for the individual and or for the people around them. These predispositions are inflexible and maladaptive, and they cause distress or impairment, again, either to the person or to the other people around them. So these are the DSM-5 criteria for a personality disorder. You note at the top it actually says the DSM-4 TR criteria. There's a reason for this. So when they were revising the DSM, really between like 2009 and 2013 when it came out, they spent a lot of time working on the personality disorders, because the personality disorders, something like 60% of people who have a personality disorder get diagnosed with more than one, or they're diagnosed with like unspecified personality disorder with like features of one. So what we have as diagnoses isn't really capturing what exists, right? So there was a lot of research that went into this. There were several calls for comments from the public about, how should we be doing this? They came up with brand new criteria for the personality disorders, a little more dimensional, much more clear. And they submitted these in October, I believe, of 2012. DSM-5 came out in 2013. And they were told, we're sorry, you're too late. We can't put it in there. We can't change it now. So they did these years of work for Bubkiss. And my favorite part of this is These are in the DSM-5. They just put them in the back as an appendix. So they couldn't get it in, and yet they put it in, is like the mind-boggling piece of this. I actually went to a talk in November of 2012 by the committee that did this, and I've never seen a more disheartened academic talk. I felt so bad for them. So yeah, right now, if you turn to personality disorders in the main text of the DSM-5, you will find copy-pasted the DSM-4 TR criteria. If you go to the back in an appendix, you'll find the proposed criteria for future study. So there are two different sets of diagnoses for personality disorders in the DSM right now. Confusing, annoying, right? And frustrating, I guess would be the most important word there. So a personality disorder in general is an enduring pattern of inner experience and behavior that deviates markedly from the expectations of the individual's culture. Again, think about how we talked about what's abnormal at the very start of the semester. With at least two of the following areas affected: cognition, affectivity is emotional experiences and expression, interpersonal functioning, and then impulse control, your ability to not do things you shouldn't do. This pattern is going to be inflexible and pervasive across a broad range of personal and social situations, and it's stable and long-lasting, and its onset can be traced back to at least adolescence or early adulthood. However, you cannot be diagnosed with a personality disorder until you are 18, so we don't accidentally overdiagnose adolescents who are just mood, right? And then you're going to have, again, a significant distress or impairment that can influence either you or other people or both. And I'm going to read a quote to you from the DSM, and you don't have to write this down, but just so you know how these are described. So it is only when personality traits are inflexible and maladaptive and cause significant functional impairment or subjective distress do they constitute personality disorders. So someone can have a personality you just don't like without having a personality disorder. And I think that's an important point. All right, so since we're using the DSM-4 criteria, there are actually 3 clusters of personality disorders. The first is cluster A. These are the odd or eccentric disorders. And these include paranoid, schizoid, and schizotypal. We'll talk about each of these in a lot more detail as we go through. People with these disorders have symptoms that are similar to schizophrenia in some ways. So they might have inappropriate or flat affect, odd thought and speech patterns, and paranoia. But unlike people with schizophrenia, people with these disorders maintain their grasp on reality. People in cluster B seem dramatic, emotional, and/or erratic. The disorders here are antisocial, borderline, histrionic, and narcissistic. The cluster B disorders are probably the best researched and most commonly treated among the personality disorders. People with these disorders tend to be manipulative, volatile, and have difficulties in social relationships. They can also be prone to impulsive and sometimes violent behavior. They can show little regard for their own safety and the safety and needs of others. People with cluster C personality disorders appear anxious or fearful. The 3 disorders here are avoidant, dependent, and obsessive compulsive personality disorder, which is distinct from OCD. People with these disorders are extremely concerned with being criticized, being abandoned by others, and because of these concerns, they tend to have dysfunctional relationships with other people. So this is arguably the best chart, the best description of the personality disorders and how many of their symptoms overlap and why it can be so hard to diagnose someone with a personality disorder. I believe this is in your text. And so you can refer to this if you want. You certainly don't have to memorize it. But like, for example, if you look across the top row at relationship problems, right? Literally every single personality disorder shares that feature. So just by knowing that, you don't know which one they have. And so it gets trickier and trickier to sort of break these down sometimes. All right, so we're going to start by talking about the cluster A disorders, which are called the odd or eccentric personality disorders. People with these disorders display behavior similar to, but not as extensive as, schizophrenia. Behaviors can include extreme suspiciousness, social withdrawal, and peculiar ways of thinking and perceiving things. Such behaviors leave the person feeling isolated. Other people just don't really want to be around them. And some clinicians that these disorders are actually so similar to schizophrenia that these should be called schizophrenia spectrum disorders. And actually, one of these, I think it's schizotypal, is actually in the DSM, the main text of the DSM twice. So it's in the personality disorder section, but it's also listed with the schizophrenia and related disorders. Clinicians have learned much about the symptoms of these disorders, but little about effective treatment for these disorders because people with these disorders rarely seek treatment. They kind of are just eccentric and odd and don't really think they have an issue. All right, so we'll start with paranoid personality disorder. And this disorder is characterized by deep suspicion or mistrust of others. Although inaccurate, the suspicion does not get to the level of delusional, right? They don't think aliens are following them or the CIA. They just kind of think everybody else is out to get them. As a result of their mistrust, people with this disorder often avoid relationships altogether. They also exhibit argumentativeness, which can disturb, infuriate, and alienate others. They also insist on control and have a sensitivity to power. And they can exhibit pathological jealousy. Other symptoms can include hypersensitivity, vigilance, and caution with dealing with others, because again, they're paranoid about everything. Between 0.5% and 3% of adults are believed to experience this disorder. They think more men than women. In terms of treatments for paranoid PD, again, they typically don't seek out treatment. Few come to treatment willingly. And as a result, therapy for this disorder, as for most of the other personality disorders, honestly, has limited effect and moves slowly. There's a couple exceptions to that we'll talk about. But most of the time, therapy with people with a personality disorder is a long process. So object relations therapists who come out of the psychodynamic tradition try to see past the patient's anger and work on the underlying wish for a satisfying relationship. CBT therapists try to help clients control their anxiety that underlies that paranoia and improve their interpersonal skills. And cognitive therapists will also try to restructure clients' maladaptive assumptions and interpretations. That person doesn't really have to get you. There is no medication that you can just give someone with paranoid PD. Cute cartoon related to it. All right, schizoid personality disorder. This is characterized by persistent avoidance of social relationships and limited emotional expression. Withdrawn and reclusive, people with this disorder are just not interested in relationships with other people. People with this disorder focus mainly on themselves and are often seen by others as flat and cold. It's estimated to affect fewer than 1% of the population and is slightly more likely to occur in men than in women. So how do you treat schizoid PD? Well, their extreme social withdrawal prevents most people with this disorder from entering therapy unless some other disorder actually makes treatment necessary. So they may come in for treatment for depression, say. Even then, patients are likely to remain emotionally distant from the therapist. So maybe they would need the MDMA. Probably the worst idea. Don't do that. Cognitive therapists have sometimes been helpful to people with this disorder by helping them experience more positive emotions and more satisfying social interactions. So behavioral therapists will also have some success in teaching social skills. Group therapy actually can be useful, and it can offer a safe environment for social contact, so other people are experiencing the same thing. As with paranoid PD, drug therapy is of little benefit here. There isn't just a magic medication we can give. All right, schizotypal PD is characterized by a range of interpersonal problems, odd or even bizarre ways of thinking and perceiving, and behavioral eccentricities. These symptoms may include ideas of reference, so thinking things that are on the news are directly related to them, and or bodily illusions, so thinking that something just like the walls are breathing if you're on LSD, maybe you think that your arm is breathing on its own or something like that. They tend to have odd cognitions, so paranoia and suspiciousness. They perceive others as deceitful or hostile, and social anxiety can come out of that. They tend to believe that random events or circumstances are related to them, those ideas of reference. So they might, for example, think it's highly significant that a fire occurred in a store where they just shopped yesterday. Right. So overthinking things. Odd beliefs and magical thinking. They might believe other people can read their thoughts, for example. Illusions. So these are just sort of hallucinations, seeing things in the patterns of wallpaper, things along those lines. They may experience some disorganized speech. They may be tangential, so start talking about one thing and then quickly transition into something else that's highly unrelated. They can be vague. It can be difficult to determine exactly what they're talking about because it's so global and abstract. And sometimes they over-elaborate. They may have very florid speech when they describe every detail of an event. People with this disorder often have great difficulty keeping their attention focused. Conversation is typically digressive and vague. People with this disorder are socially withdrawn, and they typically seek isolation and have few friends. So maybe 2 to 4% of people have this disorder, but again, slightly more males than females. And as I mentioned previously, this is listed in the DSM-5, both in the personality disorders and in the schizophrenia category. Therapy is really difficult here, just like with the other 2 cluster A personality disorders. Most therapists agree on the need to help clients reconnect and recognize the limitations of their thinking and powers. Cognitive therapists further try to teach clients to objectively evaluate their thoughts and perceptions. And antipsychotic drugs appear to be helpful in reducing certain thought problems. So here's one of the exceptions where a psychotropic medication can actually help. All right, so we are going to stop there for today. And then we'll start talking about the cluster B disorders on Thursday, and then we'll finish the cluster C's, talk about the new criteria, and how how we theorize about personality disorders. So, do some good thinking about how you want to approach the end of the semester, whether or not you want to take the exam a week from today. And again, if you need any consultation with that, please reach out to me via email. And yeah, have a good couple days. I'll see you all on Thursday.